Hello, everyone. Welcome to our Zoom meeting. And today we will have different topics. We're going to start with Dr. Dalia and gait impairment. And then we have Dr. Amr will talk about Elicit, one of the tools that we can use for systematic review, followed by Dr. Almar, inshallah, talking about rural health and the tools that can be used. When you are ready, Dr. Dalia, please go ahead. Thank you.
Okay, sure. Thank you, Dr. Nader, for this opportunity. And thank you for all who is going to attend this lecture. I'll start sharing my screen. Do you see my screen?
Yes, Dr. Dalia.
Okay, great. So hello, everyone. My name is Dalia Ali, and today I'm going to discuss a topic that is highly relevant in the care of older adults, which is the gait impairment. And as we know that gait issues are not only common, but are also important predictors of functional decline and also for the loss of independence in older adults. So understanding the gait impairment is crucial because it affects a significant portion of the older population. For example, at least 20% of the community dwelling or non-individualized and institutionalized older adults, they report difficulty walking or they require assistance. And this prevalence increases dramatically with age and underlying health conditions. So by the end of this session, we'll be discussing the objectives of this session, how to perform a diagnostic evaluation of gait dysfunction, and how to conduct a gait assessment of the older adults. In addition, we also going to be able to understand interventions that can possibly reduce impairments. In addition, we will also explore the epidemiology of the gait disorders, the conditions that contribute to the gait impairment. We'll be able to how to do a gait assessment, and we'll also explore the interventions to reduce gait disorders. So epidemiology of gait disorders, gait disorders are common and a predictor of functional decline. And at least 20% of non-institutionalized older adults, they admit to their difficulty with walking or require the assistance of another person or a system of special equipment to walk. And in some samples of these older adults, those mainly above 85 years old, the prevalence of walking limitations can be over 50%, which is a significant percentage. So age-related gait changes such as slowed speed and most apparent after the age of 75 or 80, but most gait disorders appear in connection with underlying diseases, particularly diseases that Parkinson's disease, systemic diseases, and so on. And as disease severity increases, the gait impairment increases. For example, in advanced age, above 85 years of old, also with having three or more than three chronic conditions at baseline, the stroke, the hip fractures, or cancer, they also predict the catastrophic loss of walking ability. This slide provides an overview of the common gait abnormalities and their definitions. It's a bit detailed slide, but generally we just need to know that understanding these terms is essential for recognizing different patterns of walking problems in older adults. For example, the antalgic gait is a limp caused by pain, while the foot drop results from weakness in the ankle dorsiflexion. The circumduction, from its name, we can see that it's an outward swing of the leg in a semicircle from the hip. The equinovarus, it's excessive plantar flexion and inversion of the ankle. The festination gait, which is the most common or the first gait impairment that we knew about in medical school related to the Parkinson's disease, which is the acceleration of gait. The foot drop, where we see loss of ankle dorsiflexion secondary to weakness or of ankle dorsiflexors. The foot slap, where we see early, frequent, audible foot floor contact with a stepping gait compensation. We also know about the freezing gait, which is sudden short duration diminution or cessation of walking, usually associated with a shift in attention or movement circumstance or direction. And each abnormality has distinct features that can help us identify the underlying causes and guide our assessment and interventions. More terms for gait impairment, they all mostly come from the name itself. It's like genu recurvatum, related to the knee. It's usually comes with hyperextension of the knee. Propulsion, where the patient tends to fall forward. Retropulsion, where we see tendency to fall backward. Scissoring, where hip abduction is visible, such that the knees cross in front of each other with each step. The steppage gait, which is an exaggerated hip flexion with knee extension and foot lifting, usually accompanied by foot drop. The also well-known Trendelenburg gait, which we see shifting in the trunk over the affected hip, which drops because of hip abductor weakness. And finally, the turning block, which is moving of the whole body while turning, rather than turning just the head or the neck only. Conditions contributing to gait disorders in primary care. We see that gait disorders in older adults are usually multifactorial. And several conditions can contribute to the gait impairment, including degenerative joint diseases, musculoskeletal deformities, intermittent claudication, orthopedic surgeries, stroke with any residual weakness, post-stroke as well, postural hypotension, dementias with different types of dementias, fear of falling, and also vision loss. And so based on these factors, recognizing these contributing factors is important actually, because it helps us understand that gait problems often result from a combination of medical, neurological, and even psychological issues. The classification of gait disorders is generally based on the level of the sensory motor dysfunction. And we generally can group gait problems into 4 main categories. The low-level disorders, which are subdivided also into include peripheral sensory dysfunction and peripheral motor dysfunction. The middle-level disorders involving the postural and the locomotor impairment. And the high-level disorders, from its name, it is related to the higher function of the brain, the cognitive and the white matter changes. And it's important to note that some conditions, such as Parkinson's disease, may affect multiple levels at once, like both cortical and subcortical structures. So understanding this classification helps clinicians identify the underlying causes of gait problems and tailor interventions more effectively based on the original or the level of the deficit. Going through each level of neurodeficit to classify the gait impairment, we'll walk through the peripheral sensory dysfunction, which can have a major impact on walking. It's actually when someone loses, for example, like when someone loses touch or position sense, such as with peripheral neuropathy, they may develop a wide base, unsteady or uncoordinated gait. Often they lift their feet high and slap them on the ground to increase the sensory feedback. Also, the vestibular disorders, which affect the balance, they can also cause a weaving gait or a tendency to fall to one side. In addition, also the visual impairments lead to a tentative or uncertain way of walking. So recognizing all these patterns may help us identify the underlying sensory issue and to choose the right intervention thereafter. The second level could be also the peripheral motor dysfunction. It can significantly impact the walking. For example, painful or deforming conditions such as arthritis, hip, knee, or spine issues can often lead to pain and decrease the motion. It can result in antalgic gait with a shortened stance phase of the affected side. And the stance phase is actually the stance phase of the gait cycle. It represents the period when the foot is in contact with the ground and bearing the weight. I think the gait cycle has like 4 phases. The stance gait is where the foot just comes in contact with the ground and bearing the weight. You might also see trend impaired gait or buckling of the painful limb when bearing weight. Other focal myopathic or neuropathic weakness, whether proximal or distal, they can cause also exaggerated lumbar lordosis, trend impaired gait, waddling gait, or also steppage gait with foot drop or foot slap. And most of these gaits, I think, are overlapping. Again, recognizing these patterns also helps us identify the underlying motor issues and select the appropriate intervention. The peripheral and locomotor impairment, for example, the cerebellar ataxia leads to poor trunk control and other incoordination deficits of the cerebellar problems, resulting in a wide base gait with increased trunk sway, irregular stepping, and staggering gait, especially when turning. And for example, also the Parkinsonism is characterized by rigidity, slow movements, tremors, and the stoop posture, which often causes small shuffling steps, which we call usually the destination gait, the hesitation in walking, the propulsion, the retropulsion, and even the turning block is also seen in Parkinson's disease, the absent arm swing, and the freezing of gait as well. Hemiplegia and hemiparesis also, which involves weakness or spasticity in one side of the body. And it can cause leg circumduction, may cause loss of arm swing and foot drag or scrape on the floor. The paraplegia and paraparesis, also affecting both legs, may result in bilateral leg circumduction, scraping feet, and sometimes scissoring. Moving up to the higher defects and the cognitive and white matter disorders. Cognitive and white matter disorders can also have a major impact on gait. For example, conditions like frontal lobe disease, dementias, or normal pressure hydrocephalus may cause cognitive impairment, weakness, spasticity, or urinary incontinence, seen mostly with normal pressure hydrocephalus. These changes can lead to a range of gait abnormalities, such as difficulty initiating walking, freezing, leg apraxia, or shuffling gait that resembles Parkinson's disease, but it's with a wider base and upright posture and preserved arm swing. It's a little bit kind of looks like the Parkinson's with this a few differences. In mid to late stage dementia, either dementia to Alzheimer's disease or vascular dementia, individuals also may develop a cautious gait with a normal to widened base. They may also have shortened stride or decreased walking speed, and even in block turns. Gait assessment and the key points of gait assessment. This slide highlights the essential steps and considerations in assessment. The key points include initially, as usual, a very careful medical history and a thorough physical exam. This helps us identify the underlying factors contributing to gait problems, such as chronic diseases, any recent illnesses, or any medication side effects. And lab, the second step usually in any assessment is to do lab test and imaging, but lab test and diagnostic imaging are not always necessary in gait impairment, but they can be valuable if the history and exam suggest any systemic or neurological cause. And also the use of gait assessment tools. Use of gait assessment tools is also essential. We often use standardized tools like the well-known timed up and go test, which is also called the tuck test. And this quick test assesses the functional mobility balance and fall risk. It involves timing how long it takes a person to stand up from a chair, walk 3 meters, turn and return back and sit down, and it counts exactly the time where the patient moves his back from the back of the seat until the time the patient comes back to the seat and rests his back on the back of the seat again. Measuring comfortable gait speed also is a tool. It's important to measure a person's comfortable or usual gait speed. And this is a simple, actually, but powerful indicator of overall health, and for also the fall risk and the functional independence. We use it both to assess the current state and to track the progress over time. But always remember that most gait disorders are associated with underlying disease. So our assessment should always consider the broader medical context, not just the walking pattern itself. The first step in assessing a patient with gait disorder is, as we said, the history and exam. So when evaluating gait impairment, the very first step is a thorough history and physical exam. This helps us uncover any underlying medical conditions or recent illnesses that might be contributing to walking difficulties. And once we have this foundation, we look for evidence of subacute metabolic diseases, acute cardiopulmonary disorders, or other acute illnesses. We also try to identify motion-related factors by provoking both vestibular or orthostatic responses. For example, like doing the 𝗱becque test, which can help us check for vestibular dysfunction, and also measuring blood pressure while lying down and standing to rule out orthostatic hypotension as a cause. And finally, the vision screening, at least for acuity, is essential, since even minor visual loss can significantly affect the gait and increase the fall risk. Continuing in the history and exam, physical exam, the next important aspect is to evaluate the musculoskeletal system in detail. So after gathering a thorough history and performing an initial physical exam, it's essential to assess the musculoskeletal system, the neck, the spine, the extremities, and feet for pain, for deformities, and for the limited range of motion. We also have to pay special attention to subtle hip or knee contractures, as this can also significantly affect the gait. Another key step is measuring the leg length discrepancies, which can occur with hip prosthesis and may either precede or follow low back pain. This leg length discrepancy is simply done by measuring the distance from the anterior superior iliac spine to the medial malleolus. And so identifying these musculoskeletal factors help us understand the mechanical contributors to gait impairment, and they also guide us towards the targeted interventions to help with the gait impairment. History and exam also should include a formal neurologic assessment. It's very critical to assess the strengths and the tone, the sensation, including proprioception, positioning, coordination, including cerebellar functions, the station, and the gait. It's very essential to do the Romberg test to screen for simple postural control and whether the proprioceptive and the vestibular symptoms are functional. As we said, we can do the 𝗱becque maneuver. Given the importance of cognition also as a risk factor, assessing cognitive function is also indicated. As we said also Alzheimer, dementias, they can also lead to gait impairment. As I mentioned before, lab tests may not be necessary, but when a systemic disease is suspected as a contributor to gait impairment, lab tests such as simple lab tests or basic lab tests like complete blood count, serum chemistries, vitamin B12, and other metabolic studies may also be useful. However, imaging studies like radiography, CT scan, or MRI of the head or the brain or spine are not routinely indicated. These should only be considered if the history and physical exam identify a specific neurologic abnormality or suspected neurological abnormality, either those that preceded the gait disorder or those of recent onset. And this approach ensures that diagnostic testing is just targeted and appropriate, avoiding any unnecessary procedures or any costly procedures. Performance-based functional assessment. There are a few tests that are applicable to assess for the gait disorders, such as the comfortable gait speed and related endurance measures, such as the 6-minute walk test. These are powerful predictors of important outcomes like falls or disability, hospitalizations, institutionalization, or even mortality. In other words, how fast or how far someone can walk tells us a lot about their overall health and their overall risk. So how gait speed is measured? Usually gait speed is typically measured from a standing start over from standing and then walking over a distance of 4 meters. This is a simple, quick test that can be done in almost every clinical setting. And usually a speed of 0.6 meter per second has been proposed as a cut point for this mobility, meaning that a significant reduction in mobility. On the other hand, speeds greater than 1 to 1.2 meter per second are associated with better functional outcomes and increased life expectancy. So when we see the speed is higher than 1, this is a positive sign for the patient. Upon clinical application, these measurements are not just numbers. They help us identify patients at risk or at higher risk and track their progress over time. They can also guide our interventions and help us set a realistic goals. We'll go on details a bit on the timed up and go test, the TGRF test. This is the most widely used test by clinicians, and its speed and for its simplicity. Though several other standard evidence-based methods are also used. As I said before, the timed up or the and go test, the TGRF test, it measures the time it takes for a patient to stand from a chair, walk 3 meters, turn, and sit back down. It's a standard tool for assessing mobility and risk of the fall. Other tests may include also the short physical performance battery, which combines speed, balance test, and also chair rise capabilities. We can also use the dynamic index or the functional gait assessment, and this usually evaluates the patient's ability to adapt their walking to the changing demands, like stepping over obstacles or turning or navigating stairs. Upon approaching an older adult with gait impairment, we need to keep a few points in mind while we are trying to help and find the interventions to apply to reduce the gait disorders. So many conditions causing a gait disorder are at best only partially treatable. They are mostly a bit difficult to treat, but we can also help. Other outcomes such as pain reduction may be equally important in justifying treatment. Comorbidities, disease severity, and overall health of patient status tend to strongly influence the final outcome. And the functional improvement becomes the treatment goal, actually. Upon discussing the possible interventions that can help, as I mentioned, the key treatment points for gait disorders depends on the possible underlying cause. Like for knee osteoarthritis, the strength and the flexibility and aerobic exercise, especially when focused on a single goal and performed at least 3 times per week, they can moderately improve the overall function. And also, for example, for post-stroke patients, treadmill training may enhance the gait speed and the walking endurance. The electromechanical and robotic assistance can also increase the likelihood of walking. And for systemic diseases like Parkinson's disease, physical therapy, including complementary treatments, yields short-term gains in functional mobility and gait speed. So in general, medical therapy is important in gait disorders, presumably like for secondary to B12 or folate deficiency, treating thyroid disease, treating knee osteoarthritis or Parkinson's disease. They can eventually help to reach a better outcome. The other modality of intervention that we also approach or depend on in helping is the surgery. The role of surgical interventions in managing gait disorders is also essential, particularly when conservative treatment is insufficient in most of the cases. And the key points to emphasize, for example, in lumbar lordosis, it's helpful for patients with lumbar lordosis. Surgery such as laminectomy or lumbar fusion can reduce the pain, and thus they can improve walking tolerance. However, it's important to note that non-operative treatments can also provide modest interventions, modest improvements, especially in walking abilities. And also in normal pressure hydrocephalus. In cases of normal pressure hydrocephalus, the shunt placement may also lead to short-term improvements in gait. However, these improvements are not always maintained in the long term. So ongoing assessment is also necessary. And for hip or knee replacement for osteoarthritis, for example, the hip or knee replacement surgery can result in significant pain relief and improvements in gait speed and joint motion. But some residual walking disability may also persist even after surgery. So it's also worth mentioning that a multidisciplinary rehabilitation after surgery, or even sometimes the prehabilitation before the joint replacement, can also have a positive effect outcomes eventually. So in summary, while surgery can offer substantial benefits for certain conditions, the decision to proceed with surgery should be individualized, considering the patient's overall health goals and potential for functional improvement. Other modality that can we use also the mobility aids. The mobility aids or devices and other home modifications, they can make a significant difference in safety and independence for older adults with gait impairment. For example, the lifts, either internal or external, they are used to correct the limb length inequality, and they should be introduced gradually and conservatively to help balance the gait. We can also use the ankle braces, the shoe inserts, shoe modifications as well as other supportive devices like ankle braces. They can also help stabilize the foot and ankle. We can also use sole modifications, can address specific gait abnormalities. Walking shoes and proper footwear is also very essential. For example, shoes with low heels, thin firm soles, and if possible, high fixed heel collar provide better support and stability. The well-known and very commonly used the canes and walkers are also classic aids that reduce the load on painful joints, and they provide also extra support, especially for those at risk of falling. Even light touch on a wall or using furniture for support, they sometimes called the furniture surfing. They can enhance balance by providing sensory feedback. So in summary, gait disorders are common in older adults and are a predictor of functional decline. And the cause of gait impairment in older adults is usually multifactorial. Therefore, a full assessment, including thorough history and examination, must include consideration of a number of different causes. So while doing the history, taking history or doing physical exam or assessment, we have to keep in mind that we are looking for the cause as determined from a detailed physical exam and or functioning performance evaluation. And we have to keep in mind also various interventions ranging from medical, surgical, exercise, mobility aids. They all can reduce the degree of impairment through some residual impairment, though some residual impairment is often present. Now we can move on to apply what we've learned to real life scenarios. Please feel free to share your thoughts and reasoning. I have three case scenarios here we can discuss together and see. The first one is a 78-year-old man comes to the office accompanied by his daughter, who is concerned about his frequent falls. She says that he tends to fall when he's away from home. He does not fall often in his house. The patient is unconcerned about his falls. On the examination, his blood pressure and heart rate are normal, including postural responses. Visual, vestibular, and peripheral sensations are normal. Muscle strength, motion, and endurance are normal. There is no rigidity or abnormal resistance to passive motion of the joints. Gait speed is 1.18 meter per second. He steps with no difficulty over an obstacle placed in his path, with a few small steps on approach. He does not make appropriate adjustments to maneuver past furniture in the exam room or past other people in the hallway. So the question says, which one of the following is the most likely to be a factor in his falls? Is it related to A, cognitive dysfunction, B, cerebellar disorder, Parkinson's disease or Parkinsonian syndrome, or D, spinal stenosis? Any clues? There's the question mark.
Doctor, can we see the question, the full question,
Yeah,
so we can read
sure.
it? Thank you.
Sorry. I missed the slide. Sorry for this interruption. Yeah, here we go.
Thank you.
So any suggestions?
I think the no rigidity helps to rule out the Parkinson's option.
I agree with you totally.
Also, the normal autonomic also helps rule out the Parkinson.
That's a good point. I
There's
agree.
no history of alcohol, so maybe you can rule out cerebellar also.
Yeah, I don't see any cerebellar signs, basically.
So it's either the cognitive, or what's the last option? Cognitive or spinal stenosis?
Spinal stenosis, yeah.
Can we see the question?
Yeah, sure.
Thank you. I'm going to say maybe cognitive. That's my answer, because he says that it only happens when he's away from home.
That's perfect. Yeah, I agree with you. The answer is actually the cognitive dysfunction. Yeah. So this patient has difficulties related to motor planning. He does not navigate around the furniture or adapt to changing conditions in the environment. Example like navigating along others in his path. He has also inability to adapt or adjust his movement as needed. This suggests that cognitive dysfunction may be a factor in his fall, and that he's more likely to fall away from his home. This is also a point where he's less familiar with the places. And his lack of concern about also the fall is a common feature of mild cognitive impairment. So he has little insight into his cognitive difficulties and thus walks freely and falls frequently, and yet he remains unafraid of falling again, as it's mentioned in the scenario as well. And as you said, doctor, that he has no rigidity. This rules out the Parkinson's disease. He doesn't have the postural hypotension, and he has no cerebellar deficits. So thank you. The next case scenario. An 82-year-old man is concerned that his activity is increasingly limited since he fell 6 months ago. after he suddenly lost his balance. He is reluctant to go out socially for shopping or for lunch. Since his fall, he has had several near falls despite being very careful. He reports no dizziness or unsteadiness when he sits. At home, he holds onto furniture for support and confidence. On history, he has osteoarthritis, diabetes mellitus, hypertension. He had bilateral total hip replacements on the right side 5 years ago and on the left side 2 years ago. Examination, his blood pressure 148/78, his heart rate 72. He uses his arms to stand from a sitting position. He's mildly lightheaded for 30 or less than 30 seconds when he's first stands. Visual acuity is 20/30 at best correction. He has normal hearing and cognitive cranial nerves findings also, no Romberg side. Excuse me. His vibratory sense diminished bilaterally in great toes and ankles. His strength is normal, except in hip adductors. It's 4/5, unchanged since his last exam 4 months ago. He walks without assistive device at a speed of 0.63 millimeters per second. Base of support is wide, and he takes small steps. There is no Trendelenburg gait pattern. He also has difficulty turning and walking along a curved path, and not when he walks a straight path. He occasionally reaches for the rail in the hallway. The lab findings, his hemoglobin A1C is 8.2. So the question asks which one of the following is the strongest contributor to his gait impairment? Is it A, hip abductor weakness? Is it B, peripheral neuropathy? C, orthostatic hypotension? Or D, cognitive impairment? Want me to get back to the scenario? Any clues, any ideas?
The fact that it says that he has lightheadedness, doesn't that suggest some sort of postural hypertension?
It might be, but it says that he's mildly lightheaded for less than 30 seconds when he first stands, which means that he gets back to normal
Okay.
after a few seconds.
Mm.
So this patient, actually, the correct answer is B. It's peripheral neuropathy. Mostly because his history of diabetes mellitus, his neuropathy is the likely cause of his gait impairment. His gait is characterized by short steps. Slow speed, and difficulty turning. And patients usually with neuropathy often increase their base of support, and they become more cautious because they have diminished proprioceptive input in the feet. If we choose the gait impairment due to adductors, it's usually related to weakness in hip adductors, which are most likely to be manifested by Trendelenburg gait. And in this patient, he doesn't have any Trendelenburg gait, as mentioned in the scenario. And additionally, the decline in gait function has occurred over the past year, where it also states that his hip weakness is unchanged from his previous examination. Orthostatic hypotension is also not likely to be a contributor to his gait dysfunction because he has just mild lightheadedness when he stands, and it's also resolved quickly, indicating that any postural changes of perfusion are quickly compensated. So orthostatic hypotension does not directly contribute to his gait impairment per se. Cognitive, also the scenario mentioned clearly that he has no any cognitive impairment. So the last scenario is a 78-year-old man is seen for follow-up related to gout in the first metatarsophalangeal joint. He has not had gout pain for 2 weeks. He fell in his home twice in the last 2 weeks when doing his regular activities. He did not lose consciousness and does not know why he fell. He was not injured. The history, he has hypertension, he has bronchitis, osteoarthritis. He walks barefoot at home to avoid pressure on his right first metatarsophalangeal joint, and he's wearing sandals today. Examination, supine, his blood pressure is 146/78, his heart rate is 85, oxygen saturation 95%. After standing for 3 minutes, his blood pressure 135/76, his heart rate is 90 beat per minute, oxygen saturation 96%. He has intact cognition, sensation, and visual field. His visual acuity is corrected by bifocal lenses. The Dix-Hallpike maneuver is negative for dizziness or nystagmus. The range of motion is normal except for stiffness at end range of for hip flexion. Strength is 5/5 in all lower extremities and major muscle groups. Bilateral hugs valgus with no redness, swelling, or tenderness of the first metatarsophalangeal joint. His gait speed is 1.1 meter per second. So the question is asking, which one of the following interventions is most likely to decrease his overall risk of falls? Is it A, the prisms to improve peripheral vision? B, treatment for orthostatic hypotension? Is it C, referral to a community-based exercise program? Or D, footwear modifications? Any suggestions for the correct answer? What interventions that's most likely to decrease this patient's overall risk of falls? I don't know, for some reason I can't see the chat box, but anyone can.
I'm not sure about the answer, but I can help rule out the first two.
That's good. That's great. Yeah,
I think the question is it's telling us that his vision is okay, so I don't think it can be A. And also the orthostatic hypotension, he doesn't have orthostatic hypotension. It seems normal when he is supine and standing. So it's either C or D, but I'm struggling to determine which one it is. Because the question does say that he has stiffness in the muscle of the hip, so that could be maybe the indication for exercise. But at the same time, it says that he walks barefoot at home. So both of those seem like problems.
Yeah.
So I'm not sure.
So you prefer to refer this patient, or you're still not sure whether to give him a footwear modification, right?
Yeah, I'm not sure.
Okay. In the sessions we have discussed, I think this question we just went through it. I think in one of the sessions. So the actually you're right in ruling out A and B, the prisms, to improve his peripheral vision and orthostatic hypotension. So the correct answer is actually yes, it's footwear modifications. We mentioned that improper footwear is associated with faults in older adults. And studies have showed that older adults, they often wear slippers or socks or walk barefoot even in the home mostly. And sandals generally offer little support and maybe similar to walking barefoot. So both they increase the risk of fall. As you said, prisms are used to improve peripheral vision, particularly for persons with homonymous hemianopsia, which is a condition that results in visual field defects on the right or left side. And the patients usually, or the person affected may just bump into people or objects on the sides of his deficit. And this may increase his incidental falls. But these patient's visual fields are intact, and the history and exam findings do not support this as a cause. And also you said the orthostatic hypotension is also less likely, which is defined as the decline in blood pressure as of like 20/10 millimeter mercury drop in blood pressure when moving from supine to standing position. And this patient's blood pressure was actually not dropping to this level. So his second blood pressure measurements should be taken 2 minutes actually. And this patient was taken 3 minutes, even though he still doesn't fit the typical criteria for orthostatic hypotension. So for this patient, the first intervention would be to modify his footwear. Thank you so much for attendance. Here are some references for this topic. Feel free to ask any question. And thank you so much for attending this session.
Thank you so much, Dr. Dalia, for that excellent
You're
presentation. If there are no further questions, Dr. Amr, if you would like to present your topic next, if you're ready.
Yes,
Thank you so much.
just 2 minutes.
Yeah,
Just 1
sure.
minute.
Yeah, sure.
Thank you. Can everyone see my screen?
Yes.
Yes.
Okay. Is my voice clear? Yeah. Hello, everyone. My name is Amr Almuiad. Thank you, by the way, Dr. Dalia, for your presentation. Very interactive and very good. Today, I'm going to be talking about something called Elicit. It's an AI that you can use. It's helpful in screening and searching for studies when you're making your systematic review. So let's just begin. Maybe no one has ever heard of it. It's kind of a new AI, and it's very helpful when it comes to, like I said, making systematic reviews. It does a lot of the heavy lifting for you in a way. Has anyone heard of it here?
Not really.
Not really. It's okay. So basically, it helps with the searching. You can think of it like that. For example, if you have a study in mind and you're trying to comb through all the literature and comb through all the researches that have been made on a specific topic, you use Elicit AI. There's a paid version and there's a free version. I tried out the free version. It seems like it's enough. However, if you're working with a lot of institutions simultaneously and you're working on some bigger projects, then that's only when you would need the full version. Let's go here. So what's the problem? Why would you need this? Obviously, it would save time, but besides saving time, it actually helps with a lot of the problems one faces when searching the PubMed, the Embase, and the other databases. For example, let's say you're searching on PubMed. If you just misspell one word, or for example, you're supposed to use underscore or a hyphen, you would get 0 results. Like the search you make has to be very particular, has to be very exact. Otherwise, the search would yield no results. Now, with Elicit and with AI in general, if you make a small mistake, it tends to understand what you meant, and it tends to help you and kind of hold your hand while you're in the searching process. So that helps. Also, when we're using these mesh terms in PubMed and Embase, sometimes the database there hasn't been updated, so the term you're looking for hasn't really registered over there. However, with AI, it's almost instant. Whenever there's a term around, it will always be uploaded. You wouldn't have that problem. So essentially, it helps correct a human error and also save time. So that is like the advantages of Elicit and how it differs from the traditional search. So like I said, it's an AI that helps you search and extract data. It's been used a lot. It's not, the nice thing about it is that it doesn't have the same amount of, they say, AI hallucination, right? Sometimes including myself, I remember when I was doing my academic thesis, I would, for example, try using different AIs, for example, Google Gemini, to help me search for the relevant studies. Or, for example, when I was writing my literature review, I'll try to see if ChatGPT could help me find a certain study. And a lot of the time, it completely makes up a study. For example, if you're suggesting that you need a certain type of study to fit your certain thesis, then the AI will simply create it for you. And then you just have a made up source, which is a big problem. Now, the nice thing about Elicit AI is that it very rarely does it. So I'm not saying you can completely rely on it, of course, 100%, but it doesn't really have that much of a problem when it comes to that. So this is basically, if you can see these steps, this is basically how you do a systematic review. You make your question, and then you do the searching, you make sure you screen it, you extract, and then you compile the evidence, right? Now, you can think of Elicit AI helping steps 2, 3, and 4. So it helps you do the search, and you can think of it as your pair of eyes, and that helps you screen, right? And you can also use it to extract. So steps 2 through 4, the very time-consuming steps of a systematic review, Elicit AI just does all the heavy lifting for you, essentially. Something that could take maybe 5 days of 5 people each doing, it can take literally 15 minutes to find all the data you need. So it's a game changer, really. So here's what it can do, essentially. 3 things stand out. First, it has this kind of natural language capability it can understand. Like it doesn't need those strict terms. Instead of saying, for example, hypertension, it understands hypertension, blood pressure, elevation, increase in blood pressure. So it understands you well. It understands what you mean, not just the rigid words, right? Also, it makes you tables, which I'll show you in a minute what the tables look like. But it makes you these very nice, easy to read tables. It gives you very nice high yield summaries also at the end of each paper. So you can just know if it satisfies your inclusion criteria or not just by glancing at it without really wasting much time. Let me just show you the table I meant. This is one of the tables I meant, right? So it just gives you the study name. Let's say you're searching for 100 studies for your systematic review. Here's like what it would look like. So you'd have the study name, the type. Let's say you only wanted randomized control trials because it's a very high standard of evidence. It would show you how they intervened and how the outcomes, all in a nice table, so you can compare them. So this is an example of how you would use Elicit AI. So you have to, of course, make the question yourself. So this is our question. Does regular aerobic exercise reduce blood pressure in adults with hypertension? So we have our population here, which are adults diagnosed with hypertension. We have our intervention, which is aerobic exercise. We have the comparison group, which is basically people who don't exercise or sedentary, and the outcome, which is decrease in blood pressure. So the nice thing about Elicit is that this is how it will translate it, right? We would ask the question, and it would help us with all the synonyms. Like, for example, aerobic blood pressure, aerobic exercise could be used. Someone could say it, for instance, that cardio or physical activity or something along those lines. So it helps find all the synonyms very seamlessly, so we don't miss out any important papers. So it also helps kind of scope the existing literature. You get to like screen through everything very quickly because you want to make sure that you don't make a systematic review on something that's already been published, because obviously that way you wouldn't really have published something new. So it helps in that regard. It makes sure you made the study yourself originally, and your study hasn't already been published somewhere. And you can also filter out by specific study design, which is very helpful. Now, the thing is, while it is helpful and while it does save a lot of time, it still cannot directly 100% replace a human. Because a lot of these PRISMA guidelines, which you must follow if you want a systematic review to be published, they mandate that it's reviewed by a human, essentially. That you can't just completely rely on the AI. Even though it's very, very reliable, you still can't rely fully on it. So while it does save time, while you're looking for the papers, it doesn't really save time because you have to review them. But of course, reviewing the papers is much faster than finding them. So it still does help, but you can't exclude them. We already showed this. This is how it would get all the studies nice and neatly in a table. So you can just glance at them quickly and see which ones you want, which ones you don't want. So let's just do a practical example together. So we used our question, which is, does aerobic exercise reduce blood pressure? We can apply a search filter on whichever one we want. And we can make basically a column, which is like these columns here. We can add any column. And then we can export it into our Microsoft Access, into our Google Sheets, or Excel. And it says online that it can help you extract data up to 10 times as fast, right? So if you're doing 25 papers, which usually takes 12 to 15 hours, you can make the draft in under 5 minutes, but that obviously isn't including you revising it. You still need to revise it, but it can theoretically at least reduce the workload, which used to be 15 hours under 5 minutes. So here are some advantages. They're pretty intuitive. So yeah, first of all, low barrier to entry. You don't need to be some sort of expert or research veteran to use this. It's very simple and it's very, you don't really need to learn a lot in order to use it. I used it myself and I wouldn't consider myself a major researcher, but it's very easy to use. Another advantage, it helps you scope and just scan quickly all the published data on something. So it can even help you know if you're going to do a certain research, right? Because maybe it's already been done before. So Elicit helps in that regard. You get a scan of all the published data on something. And at the same time, we already spoke about this, but the AI hallucination epidemic that's going on, you don't really have as much of that with Elicit. It always has like a sort of you can say source for everything it says. So it doesn't just make statements out of the wild. So that is a nice thing. Unlike ChatGPT and also Google Gemini, they tend to say stuff that they just make up. Of course, it's not perfect. It's not a replacement for PubMed, Embase, and other databases. You still need to if you want to follow 𝗱MA guidelines and if you want your research to be published. It can sometimes misinterpret data, although this is rare, especially with the newer models, but it's still something that the company says that happens. So I looked at it here. And like I said, there is a pro version, and sometimes it's required for, I think it's like maybe researches with 100+ data entries, or maybe 150. So you can't do very big researches unless you pay a monthly fee. So that is also a downside. So here I made a table. You can compare all the different, you can compare different research tools. So you have Google Scholar over here. You have PubMed, you have Elicit. So these are advanced. This is how you search for it. You can just say your question, the exact same question that's in your head. PubMed, you're going to have to use mesh terms. You're going to have to use Boolean operators. It requires someone to be a bit experienced in the research field, you can say. Well, Google Scholar is a bit in the mix. It's not that hard. It's a bit in the middle of these two. It's not that hard to search, but it's not as easy as Elicit either. Elicit has a massive search coverage, which is why one of its advantages is the scoping and scanning of all the data. And it's very quick too, so you can scan all of this in literally 5 minutes. PubMed, while it is the standard, it has a substantially lower one. Google Scholar has the highest one, but at the same time, it's considered that a lot of this information, like it's like a kind of too much information away. So it might be difficult to narrow down and see what's actually relevant to you. Automated extraction, Elicit does that for you. Neither of these two do. This is kind of the revolutionary part that saves a lot of time. I mentioned on the earlier slide, this could take up to 15 hours sometimes, but with Elicit AI, it can take under 5 minutes. So that's a big advantage here. And the big thing with these three is that you can't just choose one. You're going to have to use all three for your research, and each one has their own benefits. Elicit is the main case is rapid scoping. With PubMed, it's reproducible reviews. And with Google Scholar, it's almost everything there is to know about a certain topic. You can think of it in a way as Google itself, like it has everything about everything. So ideally, you use a mix of all three. So some takeaways, you should think of Elicit as more of an accelerator than something that is replacing your work. While it does make you more efficient, it's not replacing you fully. Also, never publish something without actually checking it manually. Of course, like I said many times now, you need to follow the 𝗱MA guidelines, which entails a human double screen. So you have to be responsible for what you publish. You cannot say that just because Elicit AI told me to do so, I'm going to publish it. It's still your responsibility at the end. And like I said in the last slide, you want to combine all of these three, Google Scholar, PubMed, and Elicit AI, in order to optimize and make the best out of your research and make it as efficient as possible. So here's the website, just elicit.com. You can try it out. That's it really. Thank you everyone for listening. If there's any questions or any comments, I'd appreciate it. Thank you very much.
All right, thank you, Dr. for this really interesting presentation. Actually, I'm rather confused as to what exactly is its job. Is it like a search bar in a way? Like how does it compare to Rayyan, or is Rayyan on you just use for screening in itself, and this one also does extraction?
Yeah, so you can think of it as it's like a chat box where you ask it a question, and the question doesn't have to be in a mesh term. It can just be a normal natural question, a natural 𝗱cie𝗁𝗁 research question, and then it helps you not only screen all the available literature, and if you have a certain pro version, you can extract the data at the same time. The free version allows you to extract data, but just not as much.
Does it also like separate, like say like it got it from PubMed? Does it separate it from like the
Yeah, it
articles
can
that,
tell you
okay.
each database, PubMed,
Okay,
PubMed,
nice,
and
nice. Yeah,
yeah,
that's really nice. Maybe I should try it. I'll give it some try.
yeah, you should.
Yeah. Any questions, clarification, guys, for Doctor? If not, I believe we're going to proceed to the next topic of today.
Just as a quick sentence, if you were to remember anything from this presentation, it's just that if you're going to start a systematic review and you want an AI to help, you shouldn't use ChatGPT and you shouldn't use Gemini. You should use Elicit AI. And the reason I say so is because it has the least AI hallucinations out of all three of them. So you won't really find the fake sources and the fake statements that you might in the other two.
Is this sponsored? I'm kidding.
It's not sponsored, but I just
Yeah.
enjoyed it.
Yeah, okay. I should like really give it a try and like I'll hopefully give a feedback. So yeah, I'm excited to actually try it.
That
And
sounds
let's
great.
see, like since you said that we should put all of the work in AI, like doesn't it technically like double your work because you're also double checking if you missed something, or does it not?
So that's a good point. But the thing is, it does take more time to screen and than it does to revise, right? Revision
Yeah.
might take a lot of time, but at the end of the day, when you add up the time you save, while you didn't save 100% of time, you still did end up saving a lot of time.
So because it's underneath like a paywall, does it give you like the entirety of the search, or like does it cut it like particular tools, right? It
It's up to
only
you.
allows you
It's up to you.
100. Oh,
No,
okay.
it's up to you. Especially the pro version, the main advantage is that you can extract as much data as you want. But in terms of giving you, for example, the study name, the type of research, for example, the database, what year, all of that stuff, it shows it to you, all of it on the free version. But in order to extract more than 100 or something like that, then you have to pay.
All right, wonderful. Yeah,
Yeah.
that's actually delightful.
Yeah.
All right. Does anyone have a question? Okay, I believe we would proceed to the next topic. Unfortunately, Dr. Almar won't be able to be here with us, although she sent me a record of the topic that she was meant to present. So yeah. Are you guys seeing my screen? And please tell me if you guys can hear.
Yeah, we
Yes.
see it.
Yeah, okay. Thank you.
If you're speaking, I'm not sure if we can hear you.
Yeah?
I don't think anyone could have heard
Yeah,
you since the
the
beginning.
recording is not working. Yeah.
Really?
Yeah.
Oh, I'm not
I thought
entirely
maybe I'm
sure.
in the wrong.
All right. Oh, I'm not sure. but did you guys hear earlier or not really?
No,
Okay,
we
wait.
didn't hear anything.
So
No, at all, yeah.
is there anything?
So it takes the vital signs, it runs preliminary
Yes.
investigations, and the
Yes
Yes.
or not yet? Yes? All right.
second
Yes, it's
thing
working now. Thank
uses
you.
AI-powered triaging to guide patients through structured care pathways. And last but not least,
Sorry, can you start it from the
teleconsultation,
beginning?
very, very
Oh,
important
yeah, sure.
because
Sure.
Thank you.
to addressing one of the most persistent challenges. Hi everyone, welcome to this presentation. Thank you so much for taking the time to attend it. I would like to welcome everyone to the session. And today we will be talking about a transformative approach to addressing one of the most persistent challenges in global healthcare, which is basically to bridge the rural health gap. So we'll be looking at how AI-enabled kiosks can play a very important role in strengthening the rural healthcare, especially since that provided that they're basically designed around real-world constraints rather than just idealized models. So as we can see in this case study material in this particular image is that the crisis is in undeserved areas, and it isn't just a static shortage of doctors. So we're not speaking of there aren't that many doctors there. We're talking about the access. There's not much access, or the access is so much harder for these patients to get. So it's going to be the lack of continuous access and basic diagnostics and timely clinical decision making. So when a patient is in a remote village and they have to travel hours just for a basic checkup that we basically get at our local hospital, the care is delayed and preventable conditions unfortunately escalate. So this is where a localized digital intervention becomes very, very important. So what exactly does an effective AI kiosk do? It basically acts, as you can see, uses AI-powered triaging to guide patients through structured care pathways. And last but not least, teleconsultation, which is very, very important because this means that we get to integrate these capabilities, and that way we can connect the remote patient with a specialist who's like miles away. However, we have to be brutally honest because these sound like great solutions, but we do have challenges and barriers facing us. So as we showed in the previous picture is that the technology itself is rarely the biggest hurdle. The actual hurdles that we're going to face is the infrastructure and the environment. In rural areas like that, they tend to have a lot of problems with power supplies, and they will have unstable internet, and as well as maintaining this hardware physically is actually really difficult, especially in the harsh conditions that they suffer from. So if we don't solve these barriers, then we're not going to be able to utilize this hardware to the best of its abilities. So what we can do is not a better algorithm. We basically can focus on the human capital. So they're designed to empower, not replace. And this is a very big problem that we face in AI is that we want it to support, not replace. So we don't want it to replace the local healthcare facilitators and the frontline workers. So by providing them with structural clinical decision support, we basically reduce the immediate dependency that these patients have on scarce physicians, while we make sure that the community feels like they can trust it and they still have a cultural acceptance towards it. So from a clinical governance standpoint, we have to establish a strict boundary. So once again, AI must remain as an assistant and should not maintain any sort of authority more than the physician that's actually there. So rural healthcare is complex and full of ambiguous clinical scenarios, and you need contextual human judgment. So the goal of the kiosk is to augment human decision making, making sure that it's safe with all the data that AI has, without removing the critical human element. So it's very important that the human element is there. At the end of the day, we made AI. So when we look at it from like a systems perspective, these kiosks should never operate as isolated islands. They basically serve as powerful nodes within a broader hybrid care network. So they facilitate early detection of that is typically not really there in rural settings. So to make this more on the long term viable, we have to closely look at the financial sustainability. Of course, an idea of that scale does have some financial responsibilities that we need to take care of. So deployment costs, ongoing upkeeps, and workforce incentives, they must perfectly align with realistically utilizing this pattern. So if the community doesn't trust the system, we're going to have a big problem here. Or for example, if the referral linkage to higher medical centers is broken, you're losing. So the investment basically fails. So sustainability requires a balance of local trust and robust financial planning, obviously. So in order for us to be able to bring this vision to life, we have to follow a structured 4-phase blueprint. So the first one is setup. Identify community hubs, establish power net backups. As we said, the internet instability can be a huge problem in this, and address infrastructure constraints. Second of all, trust. So by training the local facilitators to drive the community adoption, it's going to greatly help. So onboard and train respected local facilitators to act as trusted clinical intermediaries. And afterwards, we need to establish network connection. So establishing a direct, reliable triage escalation loops and referral paths to higher tier hospitals. And last but not least, activate assistive AI algorithms and not an AI that will take over to stream diagnostic metrics and standardized care pipeline. So ultimately, when implemented thoughtfully, AI kiosks do more than just extend healthcare access. They actually redefine how care begins in rural communities. And we always want to do the most for rural communities because it's really difficult to get the most basic care. So I want to credit the insights and framework captured in the images for anchoring today's discussion. Actually, it's always helpful to have a visual, just a visual of what's going on. So thank you so much for your time, and I would love to open the floor to any questions, or if you guys have any thoughts or anything you would like to share. And thank you so much for listening.
All right. So that's about it. So interestingly enough, we've covered Bloom as an application here as well. Although Dr. Almar could not be here with us, she used this application in which we've spoken about before. And something that I caught that I didn't actually when I was I had introduced I was responsible for presenting Loom once before, like a few months ago. And so I noticed, I don't know if you guys noticed, it was stagnant on a 1.2 speed just because I finished the free trial at that point in time, and it skipped on some just a little bit, maybe like 5 seconds. So that's an interesting thing. So yeah. And yeah, that's about it. If anyone would like to share or have something, feel free. If not, we are going to proceed to Dr. Malaz's topic, which is actually very interesting. I believe this AI bot is here in KSA. It's about Dr. 𝗱𝗁, the first AI robot here in KSA. Yeah. Wait. Let me just close my screen. Yeah.
Hello, everyone.
Hello,
Dr.
Dr. Malaz.
𝗱𝗁𝗱, I think Dr. 𝗱𝗁𝗱𝗱 opened her mic. Do you want to say anything?
Yes, I just wanted to ask regarding the AI presentation. Like, is it in use or is it just an incentive that may be used in future?
I believe it's an incentive. I saw the first link, or maybe they're starting, because a kiosk right now, like, we cannot imagine. Even when Almar was telling me about her topic, she said, "What an interesting and brilliant thing."
Yeah.
But yeah, with Starlink, I think it's within the near future. So yeah, we saw it in LinkedIn. We saw the topic in LinkedIn, so we wanted to publish it and to just share. Yeah.
Right. It was a great one. Very interesting.
Yeah.
Thank you.
Yeah. Dr. Malaz, go ahead.
Is it clear, Dr. Lujane?
Yep, it's clear.
Okay. Hello everyone. Firstly, I would like to thank Dr. Nadir for giving me this opportunity, and thank you even so, Dr. Lujane. I truly appreciate the chance to bring a timely and thought-provoking digital health case to our TGRF meeting. My name is Dr. Malaz, and today I will be presenting a news-based case discussion titled "The World's First AI Doctor Clinic Opened in Saudi Arabia." So let me start with a simple scenario. Imagine a patient walking into a clinic with cough, shortness of breathing, and chest discomfort. Usually, we imagine that the first clinical conversations begins with the nurse or physician. But in this case, the first interactions begins with an AI doctor. The patient enters symptoms through a digital interface. The AI asks follow-up clinical questions, reviews available clinical data, suggests diagnosis, prepares a treatment plan, and then a human physician reviews and gives the final approval remotely. This is the model described in the recent LinkedIn post about Dr. 𝗻𝗺, an AI doctor clinic reportedly deployed in 𝗱𝗺, Saudi Arabia. What makes this case powerful is not only that AI is being used in healthcare. We already know that. The real shift is where AI is being placed in the clinical pathway. It is no longer only working in the background as a tool for documentation, imaging, or prediction. It is being positioned at the front door of clinical care. So today, I'm not presenting this as confirmed clinical evidence, and I'm not presenting it as promotional story. I'm presenting it as a strategic case discussion. What does this model tell us about the future of AI-led care, physician oversight, regulation, business models, and patient trust? Through this poster, I will walk you through the 5 key points from the post: the clinical breakthrough, why Saudi Arabia, the architecture behind Dr. 𝗻𝗺, the business model shift, and finally, the most important question: we can build the trust layer first. And as we discuss this, I want us to keep one question in mind. So at the end, I will open for questions, for discussion. If an AI doctor clinic opened in our healthcare system tomorrow, would we be clinically, ethically, legally, and operationally ready? So now, after setting the sense, let us move to the first and most important point in this post: the clinical grade breakthrough. This is the point that makes the story worth discussing, because if Dr. 𝗻𝗺 was only another chatbot giving general health evidence, it would not be a major shift. And if it was only a co-pilot helping a doctor in the background, it would still fit within the usual direction of medical AI. But according to the post, Dr. 𝗻𝗺 is being presented differently. It's described as an AI doctor that runs the first layer of the clinical workflow. This means the AI is not only answering questions, it's actively involved in how the patient journey begins. The patient starts with triage and symptoms intake on a tablet. This means the first clinical data are collected digitally. The patient's symptoms, concerns, and initial presentation. Then the AI continues with clinical style follow-up questions. This is important because good medicine is not only about collecting symptoms, it's about asking the right next question. For example, when did the symptom start? What makes it worse? What associated symptoms are present? And whether there are any red flags. Then the post says the system can support ECG and X-ray analysis. This moves the AI to one simple conversation. It's just a multi-modal workflow where the system is not only reading text, but also interpreting clinical data and investigations. After that, Dr. 𝗻𝗺 reportedly generates a diagnosis, suggests a prescription, and provides medication guidance. This is the part that makes the case clinically serious, because diagnosis and prescription are not administrative tasks. They are high responsibility clinical decisions. But the key safety point is that the AI does not hold final authority. The post clearly states that human physicians sign off remotely, and doctors hold final authority. So this is not a story of AI completely replacing doctors. It's a model where AI runs the workflow, but human physicians remain responsible for approval. For me, the real breakthrough is not only what the AI can do, is where the AI is placed. So traditionally, AI has been placed behind the clinician. It supports imaging, documentation, risk prediction, or decision support. But here, AI is being placed at the front door of care at the moment when the patient first enters the clinical pathway. And that changed the whole discussion, because once AI becomes part of the first clinical encounter, we are no longer asking only, can AI give a correct answer? We have to ask, can AI safely manage the early steps of real patient care? Can it definitely identify the red flags? Can it know when not to continue? Can it escalate to a physician at the right time? Can it avoid overconfidence? Can it work safely with real patients, not only controlled cases? So the post also mentions a pre-trial error rate of under 0.3%. That sounds impressive, but we must be careful. A pre-trial error rate is not the same as independent real-world clinical validation. It tells us that the system may have performed well in a controlled setting, but it does not yet prove safety across diverse patients, complex conditions, and unpredictable real-world clinical presentations. So the strongest message from this first point is Dr. 𝗻𝗂 is not just a medical AI tool. It represents a possible shift from AI as background assistant to AI as first contact clinical workflow under physician oversight. So that is why mentioned as a clinical grade breakthrough. So if moving to the next question, what is actually behind Dr. 𝗻𝗂? Because when we hear the phrase AI doctor, it's easy to imagine that this is just one large chat box giving medical answers. But according to the best, the story is more complex than that. So this is, let us know the architecture behind Dr. 𝗻𝗂. The boss says that 𝗱cie did not build a completely new foundation model. In simple words, they did not just create another large language model like the ones we already know. Instead, they built with the what's called a clinical usability layer, a layer that makes existing foundation models more useful and safer inside a real clinical workflow. This point is very important because in healthcare, a general AI model is not enough. Medicine is not just language. Medicine requires clinical reasoning, context, risk assessment, safety rules, and the liability to know when something is beyond the system scope. So according to that, Dr. 𝗻𝗂 uses a combination strategy. That means the system may call different models for different tasks, such as DeepSeek, LLAMA, and Queen. So instead of depending on one model to do everything, the system may use most suitable models depending on the clinical tasks. But the real strength is not only in the models themselves. The book highlights that 𝗱cie built medical knowledge graphs from more than 800 Chinese hospitals since 2016. A medical knowledge graph can be understood as a structured map of medical relationships, symptoms, diseases, tests, treatments, risks, and clinical pathways connected together. This gives the AI a medical structure to work within, instead of only generating answers from general internet-style language patterns. So also mention equality control rules and decisions pathways from real clinical operations. This means the system is not just freely generating medical advice. It's supposed to work inside rules, checkpoints, and clinical pathways that guide what it can suggest and when it should escalate. Another important point is RAG, or retrieval augmented generation. In simple terms, RAG means the AI can retrieve relevant information from a trusted knowledge base before generating an answer. This helps reduce the risk of hallucination and makes the output more grounded in clinical information. So also, in the both they mentioned fine-tuning inside clinical. Fine-tuning means adapting the AI to perform better in a specific domain. So means safety boundaries that limit what the AI can do. So in healthcare, these are essential because a confident wrong answer can be dangerous. So the boss says also the initial scope is around 30 respiratory conditions with a planned expansion to 50 conditions across respiratory, gastrointestinal, and dermatology areas. So this is important because a focused scope is usually safer than trying to make AI manage every possible disease from the beginning. So here the key message is Dr. 𝗻𝗄 is not powerful simply because it uses a large language model, but its value comes from the clinical layer around the model, the knowledge graphs, rules, decisions, pathways, RAG, fine-tuning, and so on. So this is why they mentioned MOD is not the model. The MOD is the medical knowledge that a general purpose LLM does not have. So in other words, we can say the competitive advantage is not just having AI. The advantage is having AI that is connected to our clinical knowledge, clinical rules, and real healthcare workflow. For me, this is one of the most important lessons from the whole post, because in healthcare AI, now we should not only be like putting questions which model is being used. So now we are asking what clinical safety system is built around the model. So because in real patient healthcare, the model alone is not enough. The architecture around the model is what determines whether the system can be useful, safe, and trusted. So, and this leads us also to another important question. If a technology company is no longer only building a software, but is becoming part of how care is delivered, what does that mean for healthcare businesses model? So this leads us to our fourth point, the businesses model shift. So here, this point is very important because it moves the discussions from technology to healthcare delivery. For many years, companies like Cine AI worked mainly as technology vendors. In simple terms, they built software and sold it to hospitals. So the hospital remained the care provider, and the AI company stayed mostly in the background as supplier of digital tools. But accordingly, the Saudi model suggests something different. Cine is not only providing an AI system, it's cooperating with healthcare partners to support an AI-enabled clinical service. This means the company is moving closer to the actual delivery of care, and this is a major shift. And the role is changing from software vendor to clinical workflow partner. And a software vendor software vendor sells is a tool. So a clinical workflow partner becomes involved in how patients enter the system, how symptoms are collected, how data are interpreted, how decisions are suggested, and how physicians review the final plan. So this matters because healthcare AI is no longer only sitting behind the screen. It's entering the clinical pathway, and it's becoming part of the patient journey. So in the traditional hospital technology, we know that the AI system may help doctor read and image, summarize notes, or predict risk, but this model means the AI is connected to care process itself, So it helps organize the counter, structures the assessment, and prepare the first layer of clinical decision making. So this is create a completely different level of responsibility. If AI is only background tool, the risk is one thing. But if AI becomes part of frontline care delivery, the questions become much bigger. Who wants the workflow? Who monitors the safety? Who updates the system? And who audits errors? So who is accountable if a wrong recommendation reaches the patient, for example? And how do we divide responsibility between the AI company, the hospital, the regulator, and the physician? This is why business model shift is not only a financial issue, it's also a clinical governance issue. So in the post also, they mentioned friends is a possible move from selling system to operating or cooperation. AI-enabled clinics, we can say. That means AI companies may start to behave less like traditional software companies and more like healthcare infrastructure partners. And if this model succeeds, it may open a new market, AI-powered clinics, AI-supported primary care, AI triage centers, and remote clinical decision support services. But we have to be careful. A scalable business model does not automatically mean a safe clinical model. Something can be attractive, efficient, and innovative, but it still requires strong validation, regulation, reliability frameworks, and continuous monitoring before it can be safety expanded. So here, Dr. 𝗱𝗁 is not only showing us a new type of AI tool, it may be showing us a new type of healthcare business model where technology companies became more deeply embedded in delivery of clinical care. And for us as clinicians and researchers, this is exactly where we must pay attention, because the future of AI in healthcare will not be shaped only by who has the best algorithm. It will be shaped by who can build a model that is clinically safe, operationally scalable, financially sustainable, and trusted by patients and physicians. But even if the technology is strong, the architecture is advanced, we can say, and the business model is scalable. Here, there is one question. Will patients, clinicians, regulators, and health systems actually trust it? So, will people actually trust it? So, the post mentioned the question is no longer only should AI diagnose or can AI diagnose? The deeper question is who can build the trust layer first? And this is a very powerful idea because in healthcare, trust is not optional. It's a foundation of the clinical relationship. Patients trust that the system will protect them. Clinicians trust that the tool they use will support safe decisions. Regulators trust that the technology has been evaluated properly, and health systems trust that the innovation will not create hidden harm. So when we talk about an AI doctor clinic, the most important challenge is not only clinical performance, it's only whether the AI can generate a diagnosis or suggest treatment. The real challenge is whether the whole system around the AI can make the process safe, transparent, accountable, and acceptable. So the first part of the trust layer is the physician oversight. In this model, the AI may collect information and suggest a plan, but the physician still gives the final approval. This is essential because clinical judgment is not only about matching symptoms to a diagnosis, it also includes context, as we know, uncertainty, patient preference, red flags, and knowing when something does not fit. Human oversight protects the patient when the case is complex, atypical, or outside the AI's safe scope. The second part is regulation. If AI is going to enter clinical workflows, regulators need to define what the system is allowed to do, which patients it can assess, which conditions it can manage, and when it must escalate to a human clinician. So regulation should also define accountability. If an AI recommendation causes harm, who is responsible? The physician, the hospital, or the AI company? or the software developer, or all of them together? These questions must be answered before a large-scale deployment. So the third part is patient transparency and consent. Patients should know when they are interacting with AI. They should understand that AI system is part of their clinical assessment, and they should know how human physicians are involved. This is important because trust cannot be built through hidden automation. So trust requires honesty. Patients do not need complicated technical explanations, but they deserve clear information about how their care is being supported. So the fourth part is safety monitoring after deployment. Even if a system performs well in testing, real-world healthcare is unpredictable. Patients may have multiple diseases, unusual symptoms, incomplete histories. We know language barriers, medication interactions, or social factors affecting care. That is why AI systems need continuous monitoring. Health systems should track errors, near misses, escalation rates, patient outcomes, clinician feedback, and any pattern of bias. The fifth part is clinical accountability. AI should never become a way to remove responsibility from the healthcare system. If AI is used in care, someone must remain clinically accountable. The danger is not only that AI may make mistakes. The bigger danger is when everyone assumes someone else is responsible. A safe AI clinic needs a clear chain of responsibility. This is especially important, for example, older adults are often medically complex. They may present with atypical symptoms. A serious infection may appear as confusion. Heart failure may appear as fatigue. Medication side effects may look like sinew disease. Cognitive impairment may affect history taking. Polypharmacy may increase the risk of harm. So for us, even for the geriatric care, trust is not just nice concept, it's a safety requirement. So that is why I think the trust layer is the strongest point in the post. So the future of AI healthcare will not be decided only by who builds the fastest model or the smart algorithm. It will be decided by who can build a system that clinicians trust, patients accept, regulators approve, and healthcare systems can monitor it safely. So the winning AI doctor clinic will not be the one that diagnoses first, it will be the one that earns trust first. And to earn that trust, AI must be surrounded by human oversight, clear regulation, transparent consent, continuous safety monitoring, and strong clinical accountability. So after discussing the trust layer, I would like to open discussions around one key question. The post reports that Dr. Hua had pre-trial, as I mentioned, 0.3%, which sounds very impressive. So my question is, would a reported pre-trial error 0.3 be enough for us to trust? Or would we still need independent validation, real-world safety outcomes, clear escalation rules, physician accountability, and regulatory oversight before using it with real patients? So should we trust the number, or should we first trust the system around the number?
Oh, wait, sorry. Can you repeat that, the last statement?
Can you hear me well?
Yes, yes.
In the post, they reported, as I mentioned, the pre-trial error rate is under 0.3%. Is it be enough for us to trust an AI doctor clinic, or would we still need independent validation, like real-world safety outcomes, clear escalation rules, physician accountability, and regulatory oversight before using it with real patients? should we trust the number or should we first trust the system around the number?
All right. Does anyone want to answer this question?
To be
This is
honest, I feel like the number is
option for
pretty low.
discussion. Yeah.
Are you satisfied with the
Either
0.3?
I think it's low, and I think we make the assumption that doctors don't make mistakes. I would bet that doctors make mistakes more than 0.3%.
I agree with Dr. Amr. Yeah, I think the number يعني even can go to the level of human error as well.
So,
I
but
feel like we have the unrealistic expectation with AI, like it has to make zero mistakes, when even humans make mistakes. So what's the problem?
Yeah.
yeah. Actually, for me, I would not reject this model just because it's AI. At the same time, I would not accept like it because, for example, this error rate is very low. But the most important point, because it's positioned in Saudi Arabia, I can imagine an AI doctor clinic being useful for low risk, we can say, or well-defined and protocol-based conditions, we can say, especially when it's used under clear physician supervision. It may help with access, speed, we can say, triage, and workload reduction. But I would be much more cautious if we are talking about complex patients, especially older adults in geriatric care. Patients, for example, we can say rarely present in a textbook way. If even so, like not that you can say at typical presentation. So if someone presents with a serious infection, this may be confused. But personally, before trusting this model in real clinical care, we need, we can say, more than a reported pre-trial error rate. Yeah. Even so, like, I would want to see independent validation, like real world safety outcomes, like show us the validation, the safety outcomes, the clear escalation rules, the physician accountability, the patient consent, and even so the continuous monitoring.
You mentioned earlier who was going to be responsible if it made a mistake. Was it going to be the hospital, the doctor? So I'm bringing this up because it relates to my topic. The lawsuit is going to be big if someone makes a mistake. Yeah.
Yeah, actually.
Speaking about who is responsible, I think it should simply be the company who made the AI. At the end of the day, they can't have the benefits without having any of the risks. If they want to replace someone's job, they're going to have to accept the responsibility if their robot or their AI makes a mistake.
Yeah, that would be true.
It doesn't seem fair they get to see all the benefits, but they take zero of the risk.
You mean the AI company?
Yeah.
Actually, we can't say even so, like 100% AI company we're gonna be responsible of.
Well, not 100%, but at the same time, since they're taking such a big advantage, since they're making so much money out of it, there needs to be some sort of account. They can't just blame it on the hospital or blame it on the doctor.
Yeah. Actually, even so, the point is that when there is having complex patients and so on, how they can even so adding that to the system to ensure like they covering all of the safety, real world safety outcomes and so on, to ensure there is independent validation. They will gonna they entering data and so on, as I mentioned. They depends on the AI clinic doctor, depends on the textbooks, depends on the guidelines, protocols, and so on. So what regard patients will gonna present it by complex, even so if there is you can say geriatric patients and so on. So this is actually, for me, makes sense. Like how?
Well,
According
I
to
also have
yeah,
an opinion on it, and the most important thing is patient trust. So a patient definitely trusts his physician, right? But with AI there's so many doubts, even with the patient, like would he be able to trust that whatever AI is saying is correct? And number two, what Dr. Malaz mentioned earlier, like the responsibility, whatever we advise the patient, we are held responsible for everything, right? So I think this AI tool is a very good in assisting the physician, making everything efficient, but then independently dealing with the patient. I'm not very sure if that should be incorporated into the clinical practice.
I think
Yeah.
according to your presentation, Dr. Malaz, is that it won't handle complex patient, but on otherwise they would be handling like more like simple menial tasks, such as like, let's say like the primary care physicians, like let's say, oh, a patient
Yeah.
presents to you with anemia, so this is what they can handle, like they can ask for labs or etc. So instead of actually getting a real human, I think that might be replaced. I believe it's not a matter
Mm.
of if, it's a matter of when.
Yeah. So even
Dr.
so if
Malaz,
there
I
is,
have a question for you.
yeah.
Yeah, my question is, the whole point of these AIs is that they claim to be more knowledgeable in a way and more efficient than a human. Isn't that right? So if a mistake is made, why is it not fair to blame the AI? I understand that the AI needs to have certain inputs and it has to have the full context, etc. But if all of that is provided and it's still mistaken, then it is fair to blame the AI company, isn't it?
If all that's right, just the problem is gonna be on the AI company.
But yeah, my question is, let's say all the relevant inputs are put in and mistakes still happen.
Mm-hmm.
So are you saying that's the only time it's fair to blame the AI company?
Even so, if there is like AI is working well and everything well, I can't say like if I get in your question, I can't say like yeah, so AI I can't trust it, we can use it and so on. It needs the accountability. You get my point? Like we need patient trust, right? We need physician supervision. We need the developer, right? We need even so like monitors, right? All of that, it should be working all of them together.
Yeah.
So who will get responsible from if there is any you can say error? Who will get responsible from this error? Who will gonna take the responsibility?
Right, I understand. It's difficult to point the finger at one person.
Yeah, exactly.
Mm.
And another point, Dr.
So that
Malaz.
is why, yeah, so
sorry.
that is why even so they mentioned,
Mhm.
should AI like diagnose, is this ready? You can say in the clinical, in a real clinic with the real patients. Let's see what did they find in 𝗱ص, inshallah.
Can
So
I
we're gonna
share my
show
screen?
for sure safety outcome.
Can I share my screen to show like the people something as to why I think that we're actually looking at the very, very near future. So back in 2023, there was this boy who 17 doctors apparently could not diagnose him, right? Chronic pain in the back. I think he was diagnosed with spinal stenosis or something like that, or I'm not entirely sure. So his mom puts his symptoms onto ChatGPT, and goes to confirm with the consultant, an attending in the US, and they actually go and look for it, and it was in fact the diagnosis which saved the boy a lifetime of pain. So this is why I think that AI, just in general, like the lack of judgment, and I do think it's not like end all be all, because at the end of the day, we're going to look for the empathy, the human report. But yeah, so like there are things like this as well that like, oh, doctors cannot find, and like, and I believe that it's going to be louder in the next few years that, people are going to claim that, a doctor, I went to a million doctors and I wasn't able, they weren't able to give me a diagnosis, but like I was able to find it using an AI. So yeah, so this is just an interesting thing that I would like to add to Dr. Malaz. You guys can continue.
I think the fact that this was in 2023 is the even crazier part, because that's 3 years ago.
Yeah, this was like very early ChatGPT.
Wow.
It also rings a bell in my mind what medical insurance companies would be covering an AI doctor, and how would the cost be for them in such cases.
Yeah, even so, like what the authority exactly, like the authority who is gonna be responsible from the AI doctor, because it's an AI doctor. So is it gonna be, for example, related to the like health authorities, or is it gonna be related to the, you can say, the AI authorities and so on? So you couldn't say like. So yeah, that is all, guys. This is the questions open till now, not answering. So thank you so much. If anyone have any questions or want to add anything or want to share anything.
I just think that it's the AI companies trying to hide from their responsibility. But that's just my opinion.
So
Well, we're not yet sure about that, who handles that medical legal stuff. Still not yet confirmed. But when we do hear about who's responsible, then yeah, well, Dr. Malaz will be having an update.
Of course, of course.
Okay. So yeah, if anyone has any questions for Dr. Malaz and her wonderful presentation and an eye-opening presentation as well, I would proceed to my topic, and this is going to be the last topic. Yeah, Dr. Maison said that I think AI doctor can treat the patient. So yeah. Yeah, I'm gonna have to share my screen. All right, so almost in continuation to Dr. Malaz's topic, it's about lawsuits. So the question is that, can you sue in New Zealand? Can you guys see my screen and hear me well? Hello?
Yeah, we can
Yes.
see and
Okay.
hear. You can
All
go
right.
ahead.
So can you sue in New Zealand? Long story short, you actually cannot. So back in 1974, they actually designed this concept in which nobody's allowed to sue in New Zealand. But in return, there's something called the ACC, which is the Accident Compensation Corporation. It's almost like an insurance company. I believe that's everywhere in the world. Like, you've heard of insurance companies and etc. So what exactly is the idea of ACC, right? So in most country, let's say you're a doctor, you made a mistake, or you're a surgeon, you made a mistake. The patient has to prove that someone was responsible for this mistake, or say that you were walking in the street in the city and a brick falls on you, and this was a city property. The person can show their injury, and so they can sue the city, right? So the city is meant to be responsible. So they hire a lawyer, they wait in court, and usually victims don't get anything off of it. Like It's usually in the TV in which we see like people actually winning lawsuits and they're actually getting like big amounts of compensation. But in reality, it's actually much harder than that to actually get your compensation. So in New Zealand, on the other hand, they've actually made this thing in which, oh, you just have to show your injury, you file a claim, and within like a few weeks, you're gonna get compensated, right? But all of this comes with a but. You're not allowed to sue anybody, really. So let's see if you guys would like to trade that for the lack of suing. You'd like to trade 𝗱𝗃 for the lack of suing. So let's go. So as I mentioned, how does 𝗱𝗃 work? So you show them you have an injury, you file a claim, and within 2 to 3 weeks, I believe, is that you will actually get your coverage. You'll get compensated. So what do they compensate? So they usually compensate for your treatment and rehab. So all of the treatment afterwards and all of the rehabilitation, like the weeks that you need to stay in bed for, stay in a physical therapist for, disability aids, this is all going to be paid by the New Zealand government, right? You also have your lost earning for that particular week, right? You're unable to work, so you're going to be staying at home. So they give you 80% of your salary, your ratib, basically. So, and not only that, if this surgery or quote unquote, like as I said, like you're walking in the city and it falls down on you, a brick falls down on you, and the city is responsible, the government of New Zealand is going to pay you a lump sum, like a one-time fee of 70,000. If you're permanently injured from this, like say that you permanently cannot walk or something happened. So yeah, and then you also get, if la samah Allah you died, your spouse gets compensated. Children under 18 also gets compensated, and your funeral costs are covered. So what an interesting thing that they have in New Zealand. All right, so here we put out a table and how does the world compare, or not really the world, but US. You can also say like 𝗱𝗃 is also following, and all the other places in in general. So in New Zealand, as we mentioned, you get injured, they pay you within a few weeks. You just file a complaint, they pay you, and you don't need to point fingers at who hurt you, right? Say that you were in a hospital, say that you were in a hospital and you got something happened to you. You don't need to blame anyone. Nobody gets the blame for it. In the US, perhaps, right? A doctor makes a mistake. You have to prove that they're negligent, and that's why something happened to you. You have to pay lawyers. You have to go follow the court. It could take years. You might not get anything out of it, but you have your full rights to sue. So what does this cost? And when it comes to the doctor, so this causes something called defensive medicine. So defensive medicine is when a doctor ends up asking for more lab orders, just so, like, if a patient presents with headache, you're scared that, oh, I must be sure that this person doesn't have brain cancer or something like that. So you ask for a CT, you ask for multiple, and you ask them to visit the hospital multiple times just so you can be extra sure. And what are the downsides of defensive medicine? So if you have a high-risk patient, as a doctor, you want to be safe, right? You don't want to think about the patient dying on you and the lawsuit. So people try to avoid risky patients, and they even try to avoid risky specialties nowadays. So basically here, you have doctor insurance, right? So if you're a doctor, or say that you're a surgeon practicing whatever big surgery, and you have your own clinic, you decide to open your own clinic, you have to pay this from your own pocket. Usually this is paid by the whoever employed you, but since you're doing private practice, you're meant to be paying an insurance for yourself. Specifically on the very rigorous fields of surgery, the hyper-specialized. So usually people want to be safe, and they don't usually take patients that they know are going to be very ill. So they practice that kind of medicine. Same in the NHS, same in Australia. And yeah. Okay. All right, so although this might sound like a fantasy, and every one of us would be like, wow, mashallah, that's so good. I would love to have that in my country. It's still riddled with controversies. So we have the AI-driven exits. So back in 2024 to 2025, they almost did like an automated AI service in which there was a screening almost, in which AI put 8,000 patients that were still under rehab, and AI said that, oh, 𝗱ص, they're ready to work. They don't need the rehabilitation. So this caused like a lot of people to be really mad at the system. You have the rehab performance failing. So what this means is that most of the people who end up being injured, like they stay in rehab for like 10 years and they get like the compensations and whatsoever. And so like for people to actually afford the other people that are injured, the able-bodied people, people like the younger generation, they were taxed 5% more for 3 years straight so that they could help the counterpart, the population that was actually injured. So you have complex cases left behind. So a thing here is that if you were injured and like there was a visible injury that you could show, then yeah, that would be great. But how about the invisible struggles like chronic pain and etc.? Like this is hard to prove. So, since they lost their right to sue, so how does this also go? And equal payouts. So this one actually was one of the bigger issue. So as I've mentioned, if you got injured and the injury causes you to have a permanent disability, what's going to happen is that New Zealand is going to pay you a total of $70,000. Now, this does not increase, 𝗱ص. And $70,000, they're just going to give you that one-time fee, right? So people are saying, me as, let's say, you as a 22-year-old, compared to a 60-year-old who got injured and whose life was abruptly taken away by an injury, a life-changing injury, is it actually fair to be giving you, the 20-year-old, 70,000 versus a 60-year-old 7,000? Like it doesn't compare. So now that they're injured and they can't also like do their life as they used to before. So yeah, this is also like a controversy. So we have safety is still an unfinished business. So what this means is that so I can show here under like multiple people have studied New Zealand's healthcare. As you can see, like the equity when it comes to healthcare it's lagging behind with the US. So it's still like there's still some flaws, as you can see. There's always areas to improve on, and it's not like a perfect system. Although their healthcare system is actually already on top, but there is still room for improvements. As you can see, Australia is still above. So they've been asking the question of, does removing the fault on a physician or doctor or nurse, like, does this lead to lazy doctors? Does this lead to being unable to actually remove out bad doctors? And does this cause like a lax system that's actually like unhealthy for the people? So people have actually been talking about this as well, as to the faults of the ACC. I would like to hear your thoughts on that later on. So this is what the clinicians have been saying. Some of them have been saying that it's actually great. As you mentioned, the surgeons don't have to pay 100,000 a year for insurance, for medical insurance. You have here that people don't practice defensive medicine. If you're sick, I will treat you no matter how risky you are, because you are my patient at the end of the day. And I did an oath to actually help. So yeah, and then you have also the negatives here. So as I mentioned, so it's easy to prove a broken leg or a broken arm, but how about the other issues? And you have here, as I mentioned, a system that decides when they made an error and decides compensation has lost its external impetus for quality. So meaning that does the lack of blame make doctors lazier? So this is what they've been asking as well. So as you can see, as mentioned earlier, the no fault system actually it allows a more honest like conversation when it comes to patient care. There's also few unnecessary tests. Like you don't have to over test and tell your patient to come back because you're scared that you might have missed something and you have a lawsuit tomorrow. And then you also have New Zealand is not actually safer compared to the countries. As I mentioned, as I've shown in the chart, Australia is still better. There's always room for improvement, basically. So yeah. So we have here the key takeaways of this is that in New Zealand is that they took your right to sue. No lawyers, no blame. And yeah. So do you guys think that this should be adapted everywhere else in the world? Like, should the countries of the world have the courage to have such a bold decision and to removing a lawsuit? Or do you guys agree with some of the doctors that are saying that the lack of responsibility or the lack of person to blame makes the system very lax and in return, like, doesn't help anybody? So yeah, would you guys adapt this in your countries? Like, do you guys see, would you love to see Sudan have the same thing in the near future? Yeah. What do you guys think?
I have a question about how they determine who to give the money. Because as I understand it, the whole point of a lawsuit is to prove that you have been injured by someone. So if in New Zealand, if they don't have a lawsuit, how do they determine if someone is worthy of the payout or not?
Oh, if you literally have like an injury and they can see the injury, you just file a complaint and that's it. You don't get to point fingers at anyone. They give you.
This can be abused, right?
Even, yeah, it is abused. It is one of the scandals. So as I've mentioned earlier, the people are under rehab. So what is the mystery here? Are people abusing the system? They don't actually know.
Interesting. I
So
don't,
yeah,
but to answer your question, I don't think this would be beneficial all across the world. I think it's interesting that it's working in one country, but I just feel like there's a lot of blame culture, especially in a lot, like I think most of the world actually has this blame culture where that, a lot of their pride wouldn't accept just taking money and leaving. Some people really want to point the finger at someone and say, you're the one who ruined my life.
but isn't it like, as a doctor, wouldn't you like to adopt that just
As
for
a
like,
doctor, okay,
yeah,
as a doctor, yeah, of course it would be better because you don't get blamed.
yeah.
Yeah, it's
I'm
very
slowly looking at
interesting.
that.
I've
Yeah,
never heard of this before. It's very
yeah.
interesting.
Me neither, by the way. I've never heard of it before until I saw the topic. I was like, what an interesting topic.
Yeah, it is. It really is.
Sort of my soon is gonna try to find a job in New Zealand. Good
As a
enough.
doctor, I want to be safe actually, but there should be someone to blame if some malpractice occurred.
Really? You guys, I'm sorry, I want to run.
Especially in some countries, some cultures. But New Zealand, I think, is different, and maybe the mentality of the population is different than the mentality in Middle East or any other countries. In Sudan, especially.
So do you think in Sudan we should not adopt this system? The lawsuit is better.
No, I
Okay.
wouldn't. I wouldn't suggest.
Okay.
Also, I understand very well that there is no bad doctor, but still there should be some regulation for this.
I agree.
Really, this is very interesting as a point. I thought people would agree as to with ACC because it seems like a smoother system and almost like a fantasy.
I think that it strips the patient from dignity in a way because you're basically telling them, like, okay, shut up. Here's your money. Don't talk to us about it.
Yeah. Do you know that even if you visited New Zealand as a tourist, you also get compensated?
Really?
Yeah.
That's interesting. Even
Yep.
people are visiting.
Yeah, because you're in their country.
Wow. Interesting. But I don't feel this is appropriate for any country. I feel like it's like Dr. Dalia said, it's like a culture specific thing.
Yeah. All right.
Yeah.
That's very interesting. All right. Other than this, does anybody have any question in regards to the topic? If not, as Dr. Dalia said, they are more honest and trustworthy. Maybe that's why it's only applicable for them. Hey, we could also be trustworthy. We just need a better system. I mean, in Sudan, like I really think like
I
this
like
would
your
benefit.
optimism.
I really think this would benefit Sudan. Like, I think like a lot of people, like specifically like Sudan, wallahi, yani, to see like the hospital and how it works. Like, I think
I
it
think
would
you're
really help
right.
a
I
lot.
We
do
hope
think it
so,
would
والله,
help.
yeah.
I do think it would
Ac-
help, but I don't think the people would accept it.
Actually, also, in my opinion, I think in Sudan can move towards, but it should be like introduced gradually, you can say, as
Exactly.
hybrid model. Yeah, because in New Zealand, as you mentioned, it works like you can say because compensation is separated from claim, right? So
Yeah.
the patient does not need to prove that the doctor was negligent, you can say. So the focus is on rapid support, rehabilitation, and restoring trust and so on. So ACC schemes covers injuries like on no-fault basis and so on. So meaning the claim does not depend on proving who was responsible. But Sudan currently do not have this type of national like no-fault medical injury, we can say. So today's approach is still more, you can say, solid based, where professional responsibility, negligence, and we can say the legal or disciplinary process remains central, right?
Yeah.
So yeah, and there is even so laws protect doctor and health workers from the criminal liability and so on. As you said, like they opened the law of I don't know about the laws like is there and so on, but they act within their authorized duties. So maybe actually, but it still places medical acts under civil liability, we can say. So
Well,
maybe it can be.
we're hoping to
So
see it in our lifetime that Sudan becomes like a really, really great country, you know,
mm,
after all this. So yeah, we're just trying to
Inshallah.
be optimistic.
yeah,
Yeah.
and actually we can see even so difficult because it needs stable funding, right? It needs
Yeah.
strong governance. We need like independent medical review committees. We need reliable documentation. We need insurance. Even so, we need services like rehabilitation, right? And public authorities for trust and so on. So it's still even so system Sudan system is still under like severe pressure. So yeah, we can say it's impossible, but yeah, it can be gradual to be actually intervened as hybrid model. This is from my
Inshallah.
side.
This is thank you
Yeah,
so much for your input, Dr. Malaz. Yeah.
thank you so much. Thank you so much, Dr. Vijay, for your presentation. Thank you,
Of
everyone.
course, absolutely. If anybody doesn't have anything else, I think we would like to proceed into project update. If anyone has a ongoing current project that Dr. Amr is here with us, he is a new fellow. And so if anyone would like to add him into new projects so that he can learn from the senior fellows as well, please take the stage. Dr. Maysoon, if you also have like a project that you're working on, Dr. Malaz, that you guys would like to share, of course, anytime.
Great. I'd like to thank you all for excellent presentation and nice discussion. And
Hello.
I'd like to also
Hello, Dr.
update
Hadi.
you. Hello?
Yeah, this is
Dr.
Muhammad. Yeah, today I would
Yes,
like to present here the poster crisis card. It is okay.
yes, definitely. So it's the floor is yours. Thank you.
Okay, thank you. So first I will go on to share my screen. Sorry, this is not my story. I'm not. I'm just like this. Yes. Now this is our poster. It is clear.
Yes, it's clear.
Hello.
But it's
Yes.
slightly you're not covering the entire screen, only half of it.
So now I'm focusing on the title, zooming it in. Is it
Okay,
clear
okay.
now?
Yeah, it's
Yeah,
clear in the
because
title.
I'm using my phone. I have a problem with my computer, so I'm using my phone now. So hello everyone, and today on behalf of our telegeriatric research fellowship team, I would like to present our poster. Is a care response. This is digital decision support tool designed to provide rapid non-pharmacological guidance for for managing behavioral and psychological symptoms of dementia. So I know the title is a bit little long, but let me take you through our project. So imagine yourself as a busy caregiver in nursing home, and
can I share
during
my screen if you don't mind? Sorry to interrupt you. Can I
so-
share the screen so that you can?
okay, so now I'm focusing on the background. Is it clear? My screen. Hello.
Hello.
Yeah, it's clear now. But I think this is the other one. You were presenting another one.
Sorry.
I know I'm presenting. Yeah, I'm presenting crisis.
Yes, this one. Yeah, this one.
Yeah.
Right? Yeah.
Yeah. So imagine yourself as a caregiver in a nursing home, and during a busy evening, one of the dementia residents is starting confused, agitated, wandering around, and you want to calm him. And during these situations, caregivers may be overwhelmed, stressed, and sometimes don't know what to do exactly. So the easiest solution is to give him a sedative drug to calm him, medication. So we don't want to do that. And for this, we built this crisis card. So crisis card, it is a simple website designed to help caregivers and to give them rapid solution, medications free for managing behavioral symptoms of dementia during emergency. So what to do when
Oh, wait, Dr. Asma, like, can you hold that? Dr. Nader, I think it was the other one, sorry. Yeah, the first one. Yes. Yeah.
sorry?
No, I meant this website, right? This is the website, the
Yeah.
corresponds care
This is
response.
the
Yeah,
care
okay.
response.
All right.
Yeah.
Yalla. All right,
So,
proceed.
yeah. And what you will do, so you will open the app and enter either type or select scenario from scenarios that in the website, and the website will generate crisis card. The principle of the crisis card is provide the caregiver with easy steps to follow to calm the resident and to deal with the situation. So this step is redirect by distracting him, giving him a simple task to calm him down, and like folding towel or any other task that may calm him down. And also with adjusting environment to like dimming the light, or if there is any noise, stop him. And also with reassurance, with verbal reassurance, like I'm here with you, you are be fine. So these steps, it is generated in less than 3 minutes. And so this is the this will help the caregivers. And because it is used in health settings, so we designed it to be 100% safe. So it is not generated any diagnosis or medical advice. It is collect no personal information, and also it is designed to be in simple language, so any caregiver can understand it. And also it is need no any signing, and can be used in a smartphone, on tablet, and yeah. And so our goal with this device is to stop reliance on medication to calm the patient, and to provide caregivers easy way to deal with emergency. And here is our QR code, so you can scan it and try the demo yourself, and also the other QR code for contact information. And thank you for listening to me, and I'm happy for any question. Thank you, everyone.
Thank you so much, Dr. Asma. Any feedback to Dr. Asma? This is great.
Thank you, Dr. Nader.
So a couple of comments. You did great. So you presented very brief, concise about the project or the poster or the topic, and you were to the point. So the only couple of issues is I sense you want to go fast, number one, which also you either repeated yourself or you mixed things around. You used website in one area and then the app, and then so my suggestion to you is to be more confident, and this is just when you understand the concept, I think it comes naturally. So by what I mean is, we have a problem, we are trying to develop a solution to that problem. So the problem is a population with dementia. They have some abnormal behaviors or incidents where the caregiver in their homes or in nursing homes, the setting, they cannot manage these behaviors or these conditions or incidents. They can try to solve this issue with medication or non-medication approach. So the two approaches. So we are trying to focus on the non-pharmacological approach, which is not using medications that they most of the time they use, and it goes against the guidelines by the government, for example. So we have a problem, we have a population, what the problem with the population and what the caregiver face. So the caregiver needs to calm the patients or solve the issue right there. So what we did is we used an AI based mobile application that the caregiver will use to help solve the situation, whether it's behavior, where it's confusion or other problems. So basically, we ask the AI to generate 3 steps reaction or plan to solve that issue. the plan will be number 1, number 2, number 3. The slides show that. One example, for example, is sundowning. The patient will get confused during the evening time. So how to solve this? Number 1, we'll do this, we'll get them involved, and then we redirect them and use some calming words. So this is the approach. We created different scenarios, like 60 plus scenarios that's already there. These are common scenarios, but in case there are other scenarios, the AI will generate more plans for us. This will help the caregiver to help their patients. Basically, this is the whole idea. And here the code, so you can try it yourself right now. You can create a scenario, or you can select one of the scenarios and see how the AI will generate the responses, if that makes sense. This is a nutshell of the whole project. Does it make sense?
Yes, this makes sense.
Yeah. So if they want to, they can scan, they can use their phone, they can try it and see if they have any feedback or any questions. But basically, we created a mobile application that can be used by the caregiver in their homes with their loved ones, or in nursing homes where the patients will have some kind of incident, and the caregiver will try to solve this incident by using the mobile application to either select one of the common scenarios or generate a scenario using AI, and generate a plan for a scenario using AI.
Okay, yeah.
And it's a mobile application, so the features for that application is you can download it in the device, let's say a phone, and you don't need an internet after that. It's fast, and it has 60 common scenarios. If the patient has a different scenario than all these 60s, then the AI will generate more plans.
Okay, yeah.
Does it make sense now?
Yes, yeah. This is much easier. Yeah, much easier and much natural, as you say.
So
Yeah,
just think about it in a nutshell. Just a short, brief version. If you want to get details later on, when you use this brief version, then each time you may add a little bit more information if you want to. But if you don't want, that's fine. Most of the people will come and screen the poster, and if you offer them the trial, they can try it on their phones, then it will make a lot of sense. You don't have to get into much details.
Okay, yeah. All right.
In case they have questions, most of the questions, maybe it will be answered in the poster. So the app was developed by whatever group here we have. We used AI to generate this mobile application. We verified the results by 2 geriatricians, for example, and the goal is to minimize hallucination. So these answers or plans will not be a hallucination, like most of the AI might give you some wrong information. The other 2 main concepts is this is an educational. It's not a diagnostic. We are not diagnosing dementia with using this app, and it's not clinical, like we are not giving instructions to give this medication or that medications. It's just a prototype.
Yeah.
Okay. Any comments from other fellows or any feedback? That would be great. Thank you.
Thank you, Dr. Nader. Thank you.
Thank you, Dr. Nader. Thank you, Dr. Asma. I would just like to say that I am new here, and it was a very interesting first meeting. All of the topics were very insightful, and I'm very grateful for this opportunity, and I'm very thrilled to work with everyone. Thank you.
Thank you so much, Dr. Nadia, and welcome to the program. And if you have questions, please let us know. Any of the fellows in the group or the WhatsApp group, they can answer your questions. Welcome.
Thank you very much. Thank you.
Thank you. Dr. Asma, do you have any other questions about the app or the poster?
No, at this point, I don't have questions. Yeah, but yeah, if I have one, so I will attend the other meeting and also to present the other poster the next meeting, Saturday meeting, inshallah. If it's okay.
That's okay. Yeah, that's fine.
Okay,
the concept is the same. Yeah, thanks.
Okay.
I'd like to share with you good news. We have 2 fellows in our program who joined residency program, Dr. 𝗱𝗺 and Dr. 𝗱𝗺𝗁𝗱. Both of them got accepted to residency program in New York City. And this is a last minute acceptance, like they were contacted, they approached the program, and they did over the phone interview, a very quick one, and they submit their application, and they got accepted, and now they are in the process of orientation, and July 1st will start their residency. So congratulations to both of them. So any other updates? Marta, I'd like to thank you all for joining the meeting today, and I'd like to thank all the presenters. Thank you, Dr. Lujane and your team, for great presentations and great discussion from all of you. And also, I'd like to thank those who will come to see the recording in the future. Thank you in advance. And if you have questions, please let me know, and we'll be happy to help you. See you next week. في أمان الله. السلام عليكم. For those who have any questions, please continue.
Dr. Nader, you can stop the recording, but I think Dr. 𝗱𝗺𝗁𝗱 has a question.